morning, everyone. We will go ahead and get started today. My name is Sinova Hackman. I am a program coordinator for the Delta Regional Community Health Systems Development Program with the National Rural Health Resource Center. I'd like to welcome you all to today's technical assistance webinar. We're really glad you could take the time to be here with us, especially with everything going on right now with the COVID-19. So thank you as well. Thank you again. Before we get started, I am just going to go over a few housekeeping details. When you call in, your phone line will be muted. To unmute or to remute your line, press *2. Once you call in, please keep your computer speakers on mute to avoid any echo or feedback. You can always communicate via the chat box on the left-hand side of the screen at any time, and we will go over any questions at the end of the presentation, which you may use the chat box for if you have any questions that arise throughout the presentation. The file share box, which is located directly below the chat box on the left corner of the screen, will contain a file of today's presentation and slides that you can download to your computer. Today's webinar will be recorded, and a link of the recording will be provided to you once it is uploaded to our website. Now I'd like to turn it over to Kate Stenium with the National Rural Health Resource Center to get us started.
Greetings, everyone. Thank you, Sinova, and thank you to everybody who was able to join us today. I know that we did go back and forth a little bit on whether or not to go forward with this webinar, and so I'm pleased to see that people were able to join us. I know that there are obviously organizations that are not able to join us today, and as Sinova had noted, this will be recorded and shared out to everybody within the Delta program. The topic for today's webinar is price transparency, making the most of the new 2021 CMS requirements. And we are joined today by speakers from our consulting team at BKD, which many of you are very, very familiar with BKD at this point. If you have had your revenue cycle and physician practice management assessments, you've been working closely with many of the people at the team at BKD. I just wanted to give a reminder, too, that today's webinar is hosted by the Delta Region Community Health Systems Development Program. This program is funded by the Federal Office of Rural Health Policy and in partnership with the Delta Regional Authority. So we have a couple polling questions to kick off the webinar. I'm going to have Sinova pull those up, and if everybody could take just a minute to fill out those polling questions, I will go ahead and introduce the speakers while you're looking at those polling questions and getting those filled out. The speakers that we have joining us today are Brenda Chrisman. She is a managing director at BKD. She has more than 25 years of experience helping health systems, academic medical centers, regional and national community hospitals grow their organizations through consulting services that include financial, regulatory, and reimbursement analysis. Her clinical knowledge and understanding of government and commercial payment systems bring a practical perspective to her clients. She has prior experience as a clinician, reimbursement director, and a healthcare consultant. Our other speaker today is Jackie Nussbaum, and she is a director at BKD. She has more than 24 years of experience, including extensive experience related to revenue analysis and enhancement, including strategic pricing and rate rationalization assistance for academic medical centers, multi-hospital systems, and community hospitals, market analysis for strategic decision-making, and charge master assistance in the areas of charge capture and charge structure. Jackie helps her clients with coding audits and coding and compliance consulting. I want to welcome them both. Before I turn things over to them to get started, just wanted to take a quick moment too, that chat box that you guys see over on the left side, if everybody could just take a quick second and put your name and your facility into that chat box, that would really help us and help our speakers if any questions or comments come up during the presentation. So with that, I see lots of people are typing right now. With that, I'll have Sinova take down the polls, and we'll turn things over to our speakers from BKD to get things started. Thank you.
Great, thank you. Hopefully everybody's seeing the cover page now, and I'm going to advance the slides just to make sure we're doing it right. This is, oh, what happened there? There we go. This is Jackie Nussbaum, and Brenda's going to be talking a little bit later, but we appreciate you guys joining, especially, as was said, in light of all that's going on in the world and the healthcare environment right now. So appreciate you being on here, and we think that probably others will be listening via the playback at some point when things calm down a bit. So I usually start out the presentation by talking about how there's such a great focus right now on price transparency, but I think there's still focus on that, but obviously the greater focus right now is on other topics. But we still do want to talk about price transparency today because there at this point is deadline coming up for some things that need to be done. So I want to walk through that with you. But these are today's topics. We're going to talk about price transparency and kind of what's driving price transparency at this point. And then we will get into the details around the requirements and the final rule. And then Brenda will talk about what hospitals can be doing to be ready for that requirement that's coming up at January 1st of 2021. So as I said, again, other things in the world going on right now, but really even prior to that, there really has been a lot of focus recently around hospital price transparency and pricing in general and kind of how to improve the overall price transparency of what hospitals are charging for the services that are provided to patients. And as healthcare costs continue to rise and healthcare affordability becomes an area of focus, healthcare spending is projected to consume almost 20% of the economy by 2027, according to some CMS projections. And various sources indicate one reason really for that upward spending trajectory is that lack of transparency in healthcare pricing. Healthcare economists and other experts state that significant cost containment cannot occur without widespread and sustained transparency in provider prices. So what is driving price transparency? There are a lot of things. We've listed some of those here and we'll talk through them, but rising deductibles and out-of-pocket costs. We know that the consumers, the patients, are really footing a lot more of the bill these days, or they're on the hook for a larger portion of the cost of their health care. So that's a big piece. The employer-sponsored programs and those high deductible plans are really, causing this focus. The consumers really want to know in the end what it's going to cost them out of their pocket. And we'll talk about this as we go through, is, consumers may not be as concerned about the price or the list price of a service, but again, they really want to know at the end of, the day, how much is this going to cost me out of my own pocket? And can I go somewhere else for that same service and potentially get a better price? And we'll talk this last point about prices being viewed a little bit more as retail. We'll talk about that as well. But if you think about a consumer can, go down the street maybe to a freestanding facility for their MRI versus coming to the hospital, that's what we mean by that aspect there. So we'll get into that a little bit more. So I briefly want to discuss kind of how we got to where we are today with price transparency. So we'll take it back a few steps here just to give you some of that background. So Section 2718E of the Public Health Service Act, and this was entitled as part of the Affordable Care Act, or enacted as part of the Affordable Care Act. And under this section, this goes all the way back to 2015, there was verbiage that said each hospital that's operating within the United States for each year, establish and update and make public a list of their standard charges for the items and services that are provided by the hospital. And that did include the DRGs. At this point back in 2015, there really wasn't a lot of definition. It wasn't well defined what any of this meant. So in CMS's original interpretations that were in the IPPS final rule in 2015, it said that hospitals either had to make public a list of their standard charges, and that could be a charge master or some other form that the hospitals got to choose. They either had to make that list public or they just had to post a policy for how they would allow the public to look at that list or see those charges if the public was interested in seeing those. So again, it wasn't a requirement to have that list, but just stating how the public would go about doing that. So it could have just been a statement on the website. And CMS also stated that it wanted those updated annually at that point, or more appropriate if the hospital changed its prices throughout the year. So we'll roll forward a few years to last year. At the beginning of 2019, CMS in the ITPS final rule went back and said, you know what, we want to update some of these things. We want to start getting serious about price transparency. So let's go back to those same guidelines that were in Section 2718, and let's update those to make a little more definition around some things, to make it a little more clear what we're wanting here. So at this point, and some of you may remember the requirements and what you had to do for January 1st of 2019. The rule, the ITPS rule then said that the hospitals had to list their standard charges on a publicly available domain. And what that, the bullet points there, you can see what that meant is that the hospitals have to list their standard charges for all items and services provided by the hospitals, again, to include DRGs if applicable. Again, that must be updated annually, and now there's this requirement that that list needs to be available to patients via the internet in what was a machine-readable format. And so there were lots of, definitions and guidance around what's a machine-readable format. That's not a PDF file. It has to be, a file like an Excel file that someone could download and actually manipulate that file. Skipping forward just a little bit more then to last summer in June of 2019, President Trump issued an executive order saying we need to expand the price transparency efforts. We're kind of going to turn up the heat a little bit at this point. So he directed HHS to develop additional rules that would require hospitals to publish prices, and the thought there was he wanted this to be prices that reflect what people actually pay for the services, and in a way that would be clear, straightforward, and accessible to all. I know some of you probably laugh because we think about the process, and it's not always clear and straightforward, but we'll get into that a little bit. So then what we had after that was a proposed rule. So this is all coming through the outpatient proposed rule for 2020. And so back last fall, in accordance with the executive order, CMS proposed to expand the requirements that were in place. And there was a comment period, and CMS got a lot of comments from various parties, and you can see all the different types of parties that weighed in on this. And when the final rule, the 2020 outpatient final rule was published, there actually was not a piece in there, guidelines for price transparency, but a few weeks later, the price transparency rules were published as a supplement to that final rule. So now we're to where we're going to get into the meat of this, and so we do have a final rule that back in November of 2019, CMS finalized those policies for some additional guidelines and steps that the hospitals are going to need to take around price transparency. And because, again, this was published on November 15th, and CMS wants to give hospitals plenty of time to incorporate and work through all of the requirements. You'll see there at the very bottom that these new rules are not actually effective at this point until January 1st of 2021. So, 8 months from now, these will be in effect. You can also see there the final rule if anybody's interested in going out and, looking and getting into some of the details around that. So what I want to do is go through some definitions. In the final rule, CMS outlines some definitions, and I think this is helpful compared to where things were previously, where there weren't these definitions, and it was, up to interpretation on a lot of these items as to what CMS meant. So the first definition is the definition of a hospital. So who is considered a hospital, and who has to who do these requirements apply to? So as you can see here, a hospital is defined as an institution in any state in which the state or applicable local laws provide for the licensing of hospitals. And so it really, as you read the definition, it doesn't leave a lot of hospitals out of this. And the next page we'll go over a few that are excluded. But basically, and this has nothing to do with CMS certification or CMS number. It specifically says that in the final rule that the intent was not to base any of this on, you know, your Medicare ID or anything around that. It all comes back to licensing. So if your hospital is licensed in the state in which you're in, these requirements would apply, and you can see some of the examples down there. This would be our general hospitals. This would include our critical access hospitals, still community hospitals, and the list goes on and on. You can see there at the bottom of your screen. This would also include your long-term care hospitals, your rehab hospitals. And like I said, there are a few that are excluded from this. So this requirement would not apply to federally owned or operated hospitals. The thought there is they typically don't provide services to the general public. There's a specific population, for example, VA hospitals or Indian Health Services. Those are very specific, and so those types of hospitals are not covered under the definition of hospital, and this rule would not be applicable to them. It also is not applicable to sites of service like ambulatory surgical centers and other non-hospital sites of service. CMS said in the final rule it didn't believe it had the authority to apply the price transparency requirements to those non-hospital sites of care. The next definition that was outlined in the final rule is items and services. And so as you can see here, the definition or the final rule says all items and services, and this includes individual items and services and this concept of service packages that could be provided in a hospital to a patient, and this would be in connection with both inpatient admissions or outpatient department visits, and for which the hospital has an established charge. And there are some examples here, though this is not an all-inclusive list, but the examples here would be, supplies, room and board. If you have services of employed physicians, and we'll talk about this a little bit more too, but employed physicians and non-employed or employed non-physician practitioners would be included in this. Again, it kind of comes back to this last bullet. It's really those items and services where the hospital has an established charge. So hopefully that helps. When we talk about service package, what CMS is defining here as a service package is an aggregation of individual items and services into a single service with a single charge, or really a single reimbursement. And you think about that, that would be like your per diem rates and your DRGs. And we'll talk about this a little bit more as well. The next area we really want to focus on, and this is a little bit different than the way your charges are published on your websites right now, is this definition of standard charges. There was a lot of conversation around this when the proposed rule came out, and a lot of comments that CMS received around this. So we'll spend some time on this because this did make it into the final rule. If you listen to any of those calls with CMS when the proposed rule came out, I think one reason why this was a hot topic is the way that CMS has defined what they're calling a charge. And so this first bullet point is really to go back and say what is happening with CMS is they are using the terms rate and charge interchangeably throughout the final rule, which I know is very confusing, but and I'll explain this when we talk about the 5 types of standard charges. But again, keep in mind that CMS does use rate and charge interchangeably. There was some comments during the proposed period when we get to that second bullet point where it says payer-specific negotiated charges, and hospitals were saying, well, we don't negotiate our charge with the payer. We negotiate our rates or our reimbursement. So again, this is where it goes back to CMS did not change the verbiage to be anything other than charge, but they mean when they talk about payer-specific negotiated charges, they are technically referring to the rates. So just wanted to make sure everybody's kind of on the same page with that. So what we'll do is talk about there's going to be 5 different types of charges that the hospitals will have to be publishing. And so the first one is the gross charge. And if you think about this, this is really what we would kind of call your list price or your CDM charge. So this is what you've got. There's no, this is your charge without any kind of discounts applied to that. So these, again, would be what you would see in your CDM, or sometimes these charges, like we see here in the parentheses, would sit outside of the CDM in the case of something like pharmacy, maybe some drugs, some room rates. Sometimes we see those outside of the charge master, but this is really what the hospital would charge for these items and services, kind of that base price. And then we'll get into the payer-specific negotiated charge. So the definition here is that these are the charges that the hospital has negotiated with third-party payers for an item or service. What I want to point out here is that these, again, are negotiated charges. So if you think about this, this would not include your Medicare fee-for-service, your Medicaid fee-for-service, because those are really set reimbursements. You don't negotiate those. But it could include if you have Medicare or Medicaid managed care plans, because you potentially, do negotiate the charges for those type of plans or payers. So again, this is when you're thinking about what you will have to report, thinking about those payers where you negotiate a rate. And this is the last three listed here. So you'll also have to list your discounted cash price. And in some cases, I know some hospitals may not actually have a cash price. So in that case, your cash price is really just going to be your gross charge. But if you do have a discounted cash price, maybe what you offer to a self-pay or a walk-in rate, then that's what you would publish in this column. It's not going to be your charge that has anything to do with charity care. But again, it's just if somebody were to walk in off the street and you offered a cash price for that service. And then the last two kind of go together, and these are the de-identified minimum negotiated charge and the de-identified maximum negotiated charge. So basically the way I think about this is once you've got all of your payer-specific negotiated charges kind of all laid out and understand where those are, then what you're going to do is look through that list and figure out which payer or who has my lowest charge, my minimum, and what is my maximum. And then that's what you would report in these two columns or these two charges. And the de-identified part basically says you don't have to indicate which payer that is. You're just going to say what's your minimum, what's your maximum. Obviously, somebody could go back and look at all of your different payers and kind of figure that out. But in these columns, you don't actually have to identify that payer, but it is really just kind of looking at what that range is of those negotiated charges or rates. One thing I will say is that CMS has said in the final rule that all of these 5 different types of standard charges are kind of just standalone, so that CMS would have the ability at some point to go back and pull out one of these. Maybe they would go back at some point and say, we're not going to require the payer-specific negotiated charge anymore. So they could pull that out, and then the other 4 would stand on their own. So just wanted to point that out, that it's not an all or nothing as far as the final rule goes. CMS does allow some flexibility in there to go back, and I think some of this comes down to, right now there's litigation out there about, can CMS really ask us to, publish all of these different types of charges? So there could be a point where you may still have to publish all of this with one of these excluded, if that makes sense. Okay, so now we have the definitions out of the way. I want to talk about the different ways that the hospitals have to publish this information. So the hospitals are going to have to make this information public in 2 different ways. And you'll see between number 1 and 2, we've added the word and made that bold. I think there was some confusion early, and CMS went back and clarified this, that it's not one or the other. You do have to provide this information in both ways. We will talk in another slide coming up about, for number 2, you kind of have some options or another option for this consumer-friendly file, but basically there are going to be 2 pieces you have to work through. So the first is, I would say, similar to what you're used to now, this machine-readable file. So this is going to be a comprehensive, it's one single file It could be an Excel file that has multiple tabs on it, but in the end it's going to be one file. It is going to be a machine-readable file. And in that file, then you're going to have to make public all of those standard charges that we talked through, those 5 types, and you'll see them listed there. Again, the gross charge, that payer-specific negotiated charges, the discounted cash price, and then that de-identified minimum and maximum negotiated charges. And again, going back to those definitions, this file would include those types of charges for all the items and services that are provided by the hospital. And then the second file is going to be a consumer-friendly file. This is going to be what you might be hearing as the Shoppable Services file. And so what this is going to be, and again, we'll get into this a little bit more too, I think CMS thinks this is really the file that the consumers are going to be looking for to get additional information. I've heard for file number 1 there, the machine-readable file, that CMS really thinks that's going to be information in a format that's most useful for employers, providers, folks that are developing tools to help with price transparency. That's going to be more of the user group likely for that first file. Then the second file will really be the one that our consumers will be out there on your websites looking for to try and get some of this additional information. And so you can see there, again, the second file is going to include those payer, those charges. What you will see is that consumer file does not have to include the gross charges, but it will include the payer-specific negotiated charges, those discounted cash prices, and then again the de-identified minimum and maximum. And Brenda's going to show you some examples here in a few minutes of a potential layout for those files. Okay, so here again is a little more information on that Shoppable Services file. And so what CMS has said is that shoppable is really defined as a non-urgent service that can be scheduled in advance. And again, we'll show you some examples of what those types of services might be. But again, that's how you're going to think about this Shoppable Services file as you're starting to think about the different services that are provided. That would be non-urgent services that you can schedule in advance. So CMS has helped you out a little bit by defining or coming up with 70 services of their own that everyone will report on. And these are all in the final rule, and Brenda's going to show you what those are. But everyone will have 70. Now, if the hospital doesn't have all 70, you don't have to, you would report fewer than that. But then what you have to do is come up with a total of 300 shoppable services. So if you don't have all 70 of the CMS selected services, you then have to make up additional services to come up to a total of 300. I know a lot of the hospitals on this call are smaller hospitals, and you may say, we don't have 300 shoppable services. So in the end, what you really have to do is if your hospital truly only has 250 or something less than 300 services that you would say are non-urgent and can be scheduled in advance, then it's just going to be a matter of noting that in your shoppable services file that you truly, just don't have 300. And CMS has said in that middle bullet there that the services should be selected based on the utilization or how often you're billing for those services. So you're not really supposed to just be looking for those services where you think you have a low price compared to a competitor, even if you don't really do that service very often. You really should be looking at your volume and how often you're doing those services and picking those services that you truly are, doing fairly frequently or, as frequently as you can to get to 300, I guess. This is the point I was making before, is that there is a policy in the final rule that says if hospitals offer internet-based price estimator tools, then you would have met the requirements to post your charges in a consumer-friendly format. That tool does have to meet specific requirements, and there are those specific requirements are spelled out in the final rule. And so a few of those would be that the consumer has to, at the time they use the tool, obtain that estimate of what they would be obligated to pay for that service. Your tool still has to have estimates for the 300 shoppable services, including the 70 that CMS selected. The tool has to be prominently displayed on the hospital's website and accessible without charge, and without having a patient have to register or get a username or an account, kind of a password type of thing. So those are all spelled out in the final rule, but that is another option, and we see a fair number of hospitals who were already starting to think about an internet-based price estimator tool, who are now kind of in the process of saying, is it worth it for us to go ahead and push that through now, or should we just keep working on that and create our file, a shoppable services file in the meantime. So just wanted you to understand that that is an option that's out there. But again, that tool is going to have to meet requirements. We know there's vendors out there right now who are very familiar with this and are working with, through their tools to get all these requirements built in. And you may be aware of some of those or even have, one of these tools that you're already working with. Okay. What is going to happen in the shoppable services file is that you're going to have to decide what those 300 primary shoppable services are and report on, your charge information for those services. But in addition to that, you're going to have to think through and assess what would be your ancillary services that are customarily provided with that service. And you're going to have to display, and again, Brenda will show you this, you're going to have to display on your shoppable services file these primary services along with those ancillaries as a grouping of related services. And you can see here that some of those ancillary services would be your labs, radiology, drugs, delivery room, your OR services. So any of those types of things that would normally go along with a primary service. And the way, the way we think about this is you're likely going to have to do some analysis from a claims perspective to be able to really, look at that primary shoppable service and then be able to assess and understand what those ancillary services that go along with that are. Also, if you have those professional services, if you have employed physicians or non-physician practitioners, those would need to be considered as well. As part of the services that go along. Again, that's if they're employed. So once we go through this and everybody gets their files posted, CMS has said now that they are going to have some processes in place for monitoring who's doing this and maybe who's not being compliant. At this point, there's no real formal process that CMS has laid out for monitoring, but they have said that really the way they're probably going to start by understanding this is if they receive a complaint. So say, a consumer went out to a hospital's website looking for their shoppable services file or their price list and couldn't find it. There may be a complaint file there, or a vendor, another hospital, somebody may go out looking for files and can't find them and could report those to CMS, and that's likely going to be the way they will, be looking at these complaints to start with. They have said that they don't have any thoughts right now of doing any kind of audits, but that they may be considering, those audits in the future as a monitoring method. So then if a hospital is found to be non-compliant, CMS has said that they could take the following steps. CMS would, if they do find someone not to be in compliance, they're going to issue a written warning to that hospital, letting them know that they need to get into compliance with the rule. And then if still nothing happens, CMS could request a corrective action plan from the hospital. And then if the hospital still fails to comply and doesn't submit that corrective action plan, CMS has said that they may impose civil monetary penalties on the hospital up to $300 per day for noncompliance. They did also say that they may publicize the penalties on CMS's website, and CMS has said that they have the they could deviate from this list here, but this is what's in the final rule and kind of how their initial approach will be to make sure hospitals are compliant. Now, we have heard from some hospitals saying, well, if you do the math, $300 per day for noncompliance, it works out to be about $100,000 per year. I think for the hospitals on this phone, you would probably agree that you probably can't stomach that. You probably can't afford to be non-compliant. There are some bigger hospitals who have said, maybe we just pay the penalty and, because we don't want to publicize our negotiated rates. Maybe it's worth it to us to just pay the penalty. I think some are rethinking that approach if they were thinking that now that CMS has put this last sentence on there to say they could publicize those penalties. I'm not sure anybody wants to actually be the one that shows up on CMS's website under that list. So we'll remain to be seen how much CMS digs into this compliance aspect, if those are the steps that are laid out in the final rule. The last piece I want to talk about is what CMS has indicated to be the summary of cost, or the originally I think it says summary of cost and benefits. I'm not sure where the benefit piece comes in from this aspect, but this is what CMS has estimated to be to say for hospitals to get compliant. So in the first year, CMS says that the total burden for hospitals to do this whole process of, reviewing and inventorying your different payer contracts and getting that all set up, and then to get those charges posted in the different ways that are those two different ways that are needed. They're anticipating it's going to be about 150 hours per hospital, $12,000 per hospital for a total burden there, as you see. And then subsequent years, of course, they're saying that because you've already got the process established, in subsequent years, the burden won't be as heavy. And so in subsequent years, they're anticipating about 46 hours per hospital, or $3,000. Now, if you remember back to the proposed rule, CMS estimated about 10 hours and approximately $1,000 annually to comply. So I think based on their comments, they've rethought these estimates, but I think based on the hospitals that we talked to and even just our own thinking through this, these numbers are probably very low. And of course, it's going to depend on your hospital size, how large your CDM is, how complex your payer contracts are. Some hospitals may have 15 contracts they've negotiated with payers. Some hospitals may have hundreds of contracts that they've negotiated with payers. So, obviously these are averages on here, but you think about your own situation. I think even the smallest hospitals would agree that it's likely going to take more than what CMS has estimated there. But CMS has said, and this was brought up many times in the comments, that this is a huge burden, and CMS is probably underestimated. And but what CMS came back and said was that they believe that the burdens that are placed on the hospitals to make public these standard charges would outweigh, they're outweighed by the benefit that's going to be the availability of this data and the information that it's going to provide to the consumers. That benefit would outweigh the burden that's placed on the hospitals. So with that, I'm going to turn it over to Brenda to talk about some things you can be doing to get ready for that January 1 requirement.
Excellent. Thank you, Jackie. And as Jackie had mentioned, hospitals have until January 1, 2021 to work on having the information available to share to the public. But that time will certainly be here before we know it, and certainly with the current situation, we have so many other areas to be focusing on. But we did want to spend the rest of our time getting a little more granular and talking about what we could be doing now. So noted again on this slide are those 5 types that Jackie had mentioned earlier, the 5 types of charges. And so we'll spend more time dissecting what the files might look like, as well as we'll spend some time operationalizing how to determine those 300 shoppable services that you'll need to display for your patients. So to help us do that, let's dig a little deeper into what the plain language requirement is for the shoppable services. And remember, the shoppable services file will also require sharing that negotiated charge, the de-identified minimum and max, as well as the discounted cash price for each of the shoppable services. and keeping in mind that if you don't provide, as Jackie mentioned, one of those 70 services identified, then you can note that as NA. And then also if you don't provide 300 shoppable services, you just must list the shoppable services that you do provide. And the hospital will also need to devise a way to make it clear the name of the third-party payer that's associated with that shoppable services. And I'll show you some examples of how, at least how CMS envisions this happening. And we'll also need to share what other, or you will also need to share what other ancillary services are provided with that main shoppable service. So it seems to us that this is going to require not only charge description information, but also an analysis of claim data to be able to determine what ancillary services are often provided with the primary service. In addition to the ancillary services provided with each shoppable service, you'll also need to note where that service is provided. And so CMS gives some examples of what they mean by this. An example could be services that are provided in an outpatient clinic, but then could also, that same type of service could also be provided in a hospital surgical suite. And sometimes those prices are the same, sometimes they might not be the same. And it's because some of these differences that we would suggest that if a hospital typically evaluates and changes prices annually, that you could start a little sooner this year and incorporate the evaluation of your CDM pricing and those shoppable service pricing into this process. And it would mean just taking a hard look at what you've identified as shoppable services, looking for inconsistencies, testing where you are in the market on these services, and aligning that with your overall pricing strategy for the upcoming year. So as promised, now here's an example of how CMS envisions the way a hospital would display gross charges. Okay, so keep in mind the requirement also states that you would need to display the other 4 types of charges. So payer-specific negotiated charges. So just envision how many columns that could add. And it really will depend on the number of payers you had and the number of contract terms that you have for each payer. So what we mean by that is, an example could be Blue Cross Blue Shield. You've got an HMO price or contract negotiated, and then you could have PPO rates as well. Of course, we mentioned the discounted cash price, and this might just be as simple as taking your gross charge and apply your discount to it, assuming you have the same discount, regardless of the type of charge. And then the 2 other, again, are the minimum and the maximum of that negotiated charge. One thing to note, though, is the column. There's a column on here for NDC and EHR charge quantity. I think this brings to light that the need to think not only about the charges you have in your charge master, but also the subsystems that feed into your charge master for charge generation. Hospitals may need to think about pharmacy charges, for an example, because the J-code description and billing amount dictated by that J-code, the price does not often reside in the CDM. Again, a reason why there's going to require some claim analysis too, I think. Supplies, some supply prices could be set to 0 in the charge master, and then based on the cost of that, it's getting pulled from another subsystem or could be manually entered. So it might take a bit more effort to determine the charge amount for some of your supplies. Now, Table 2 is a representation of how CMS envisions shoppable services will be presented. The shoppable service, again, is noted as the primary service. Then the ancillary services that would typically be performed along with that primary service. The CMS recommends that if other services are typically part of a service but not billed by the hospital, that these services should be noted, but there's certainly no expectation that you would know or list the charge for those. So if you look at the list of the 70 shoppable services that CMS is requiring, I think this issue will become clear. So as you approach through this process, you'll have to establish a framework of how to do this. Let's take an example of an office visit, and that's pretty straightforward. Basically, one CPT code as the primary service and not typically ancillary services, so that one-to-one match right in the middle of that table, you can see that. And then when you think about surgical services, because of the variation in the services provided for each case and the difference in contract terms, it gets more complicated. But it seems the necessary ingredients, again, will be the CDM, the claim history or your claim history, and then your contracts to understand how those services are paid. Now these next 3 slides are just to show you what CMS has deemed to be the 70 shoppable services. Again, if you provide these, you are to prepare this information in a consumer-friendly file, including the primary service, the ancillary services also provided with that, and then the 4 types of charges: the cash, the negotiated charge by payer, and the de-identified minimum and maximum. And this part of Table 3 is a screenshot of the E&M codes and the lab and pathology codes. And so take, for example, those first E&M codes are for psychotherapy. So if you don't provide this service, you can just mark as an NA. But that would mean then you would have to find other services trying to balance out the full requirement for how many you're going to provide. Now this screenshot is for the radiological procedures that are part of the 70 shoppable. And again, these are available on the CMS website as well. Now this last screenshot lists out the medicine and the surgical services. So if you notice, there are 5 DRGs that are listed here, and a hospital would need to report out the charge elements for these if the services are provided. And these DRGs include DRG 216, that's for heart valves, and then there's 460 and 473, those are spinal fusion procedures, DRG 470, hip and knee, and then DRG 743 are for uterine procedures. So in addition to these DRGs, there are also several other procedures that range from physical therapy, endoscopies, and C-sections. So again, the idea is to determine if the hospital provides a shoppable service, and if so, then we'll need to report out on these as well. I'm sure by now you're already trying to think ahead as to how best to tackle this price transparency in order to meet the deadline of January 1, 2021. So we'll spend a few minutes just talking through, at least at a high level, the plan of attack. Understanding there is still lots of clamor about whether CMS can require hospitals to post these negotiated rates, but our recommendation is to continue to prepare for it because we think hospitals will find value in this process. First, as you're doing so, just as you're doing today, you need to dig into the rules and understand these requirements, and then start to collect the data that will be necessary. CDM, that's going to your ability to identify where your shoppable services, or at least if you provide that service. The claim history to determine how to run, and that's one of the things that you probably should look for, is start to think about how to run the claim history so that you can start to see those shoppable services as well as the ancillary services. And then, of course, the contracts. Our recommendation would be to make out a grid of your contracts and start to map plan codes and determine the basic payment terms for those contracts. And then think about how the price transparency requirement will fit into your annual pricing. And there certainly would be some, oops, so let me go back one slide first. A couple other things. I think there would certainly be some economies if you could incorporate your price transparency into your overall pricing strategy. So you maybe want to alter, the price on some of your shoppable services if you see some inconsistencies when you look at the data, or if you have access to market data and you see where you compare with your peers. But really, don't underestimate this opportunity to really define what your overall pricing strategy is for the hospital. One thing for sure is this idea of consumerism and giving patients more information about what their out-of-pocket expenses are. I don't think that's going away. So definitely give some consideration to the option of providing an online patient estimator. And certainly understand from talking with our clients that this is a large undertaking, but the time is now at least to consider the return on this investment. And consider if you could share with your patient what the charges are, but more importantly, it's going to enable you to answer their questions about their out-of-pockets. How much will it be? How much will it cost them? And then follow up and ask for the payment at the time of scheduling for the service delivery. Because we know current studies do show that patients want this information, and many are willing to pay their portion if they're given that information up front. But again, the message is start now to put your plans together and don't wait, as the devil is definitely in the detail on this. And the sooner you start to untangle this web, I think the better shape you'll be in when January 1, 2021 rolls around. And we know we've certainly begun this process with some of our clients, and I think they would agree that it is helpful to engage with an advisor early on because there'll be lots of questions. And certainly we're available to assist with with the data analysis as well as with pricing strategies. But there's just one other thing that we did want to cover on or touch on, and that is we wanted to make you guys aware that when the hospital side of this price transparency rule was finalized, CMS also issued a proposed rule for health plan, or think of it for the insurance companies, the price transparency. And it seems as though hospitals really only have half of the information necessary and that the health plans hold that other half. So the purpose of this rule would be to require insurance plans to disclose price and cost sharing. The elements that were noted included the out-of-pocket amounts, the accumulated amounts, out-of-network, and then services that would be included in the estimates. And originally there was a 60-day comment period, and then CMS had to extend that for an additional, but it closed at the end of January. And so it's certainly going to be interesting just to watch to see if there's any changes when they finalize this rule as well, because the proposed rule includes similar requirements for the health plans as what we see with hospitals, including the use of an online, or the option to use an online tool, that negotiated rate file. And then, of course, we've heard so much information recently about out-of-network or those surprise bills, so there's information in there. So definitely it'll be important to watch and see how this final rule ends up. And for patients to, to have that true price transparency, all factors in this calculation will need to be known, and that includes not only what the hospital charges are, but also those insurance rules that get applied to those charges. So really with that, I think we've got just a few minutes. We'd open it up if there were any questions, but those were the prepared remarks that Jackie and I had.
Jackie and Brenda, thank you so much for sharing that in-depth information on price transparency. Just want to remind everybody who is on the line, if you have a question, you can feel free to pop it into that chat box on the left-hand side, or press *2 to unmute your lines. As we're waiting to see if any questions come through, I'll have Cineba pull up some post-polling questions. So you guys could all take a second too to fill out those post-polling questions, and use that chat box if you have a question that you would like to ask, or *2 to unmute your line. Also, as we're waiting to see if any questions come through from our Delta facilities, I just wanted to put in a plug too. Tomorrow we'll be meeting at noon, from noon to 1 Central, with our telehealth team at Huron Consulting, and they will be doing an overview of, as you know, we're getting some emergency waivers and stuff with COVID stuff to help with some telehealth initiatives. So they'll be there to go over some of that information, as well as answer any questions that any of the sites have on telehealth. So I'd really encourage you to join that discussion and that forum to learn about what's going on right now, and then to ask your questions, and also to hear from your peers on what kind of questions that they currently have around telehealth. Not seeing any questions coming into the chat box yet. Brenda or Jackie, any final comments from your end?
This is Jackie. I would just say I definitely appreciate everybody's time. We know there's a lot going on right now, and this may not be the priority. As you listen to all this, it may just get you more confused or anxious about things. But when you do start to get back into maybe a more normal mode of things, and you're starting to think about this a little bit more, certainly don't hesitate to reach out to us if you have questions, or you think back, now what do they mean by this, or we're happy at any point to help you guys talk through any of your questions, or if you need assistance with any of these files or your pricing strategy, as Brenda said. We think that plays in a lot to this.
Yeah, that is a great reminder. I know this can probably feel pretty overwhelming with everything that's going on right now with COVID. Cineva will send out the recording, and it will also be posted on our website too. So when things do calm down, to listen to that recording again